Okay, so here's the deal. We all have a little extra time on our hands, and also figured our fellows weren't operating as much as they'd like to, or as much as we could provide. So we thought, in addition to Journal Club, that we'd start a little conference that would rotate centers all around the country, giving the senior attendings at each place a chance to do a talk that's kind of dear to their heart, and then follow that up with some interesting case presentations by the fellows at that center. But the nice thing is, we've got a nationwide forum. So the whole point of this is to be interesting and to have some fun. So the first third, for each one will be golden oldies by an attending at each center. But then we'll have some case presentations and hopefully, get some discussion and questions and arguments and everything else. So that was the idea. I just really want to thank Dr. Chapman and the folks at the Seattle Science Foundation who fortunately have the technology to do this and made that part easy. So our job is just to provide some content and fun and keep it rolling. So having said all that, let me start on one of my favorite topics, which is lumbar disc replacement. So I'll kind of lead that off with that talk. And then the guys at TBI have some cases to present, and we'll get some discussion. But let me just tell you why I think lumbar disc replacement is the real deal. I'll start off with my disclosure, and that is that I do teaching and consulting for a lot of companies, and have been pretty committed to the arthroplasty space. Specifically for this talk that's pertinent, I do the similar kind of job for both Esculap and Sentinel Spine, who have the two lumbar discs that are commercially available in the U.S. and compete with each other. 19 and a half years ago, just 3 weeks after 9/11, is when the ProDisc-L study started. And this is the picture in the operating room doing the first case. And the guy who's standing across from me, who's not bent over, the guy who's bent over is the access surgeon, but the guy who's standing up in the middle is Carey Mone. And this picture was from that case in October of 2001, where Terry flew over and did the first few cases with us. That was kind of the on-the-job training, and it was good to have him here. This was done with an early first-generation digital camera in 2001, and the lighting was just spectacular. So it's a favorite picture for all of us. So I just want to, tell you that, we drank the Kool-Aid really early at TBI. Scott Blumenthal had started the Charité study in 2000, and we started the ProDisc study in 2001. It's not the first time we drank Kool-Aid, but this is the first time we drank it early, and it turned out to be a good thing. So this is the number of devices that we've put in really in 20 years. So this is, 20-year experience putting in, you can see initially a bunch of lumbars, and then as cervical studies started and cervical approvals came quicker than lumbar, the cervicals have overtaken the lumbars, but we've always maintained a pretty strong lumbar practice despite the reimbursement challenges. And most of those implants were put in by the three of us, by Scott Blumenthal, Rick Dyer, and I. Our other guys, many of whom we trained and stayed on staff, have continued to do some, but we've really stayed committed, and each one of us has put in 1,000 implants, and that sounds like a large number, but it's over 20 years. So each guy's maybe put in 50 implants a year to put it in perspective. But it wasn't always like that. The older guys listening to this remember that before 2000, there wasn't really good literature to support surgery for back pain. A lot of the older fusion studies were just a mixed bag. It had, grandma with the degen scoli along with a 19-year-old with a lytic spondy. So they just weren't really good studies. And one time for a talk I gave at the Academy, I did a lit review decade by decade. And in the 1970s, in the entire decade of the 1970s, in the JBJS, there were only 6 articles that were devoted to the role of surgery for degenerative disc disease. In the entire decade of the 80s, there were 50 articles. That's when spine started. And in the 1990s, in the entire decade, there were only 200 articles devoted to this. So going back, there was not a lot of strong data that was generated. And accordingly, many prominent surgeons, including my chairman and probably the chairman of some of the older guys sitting here, kind of poo-pooed surgery for back pain. It was sort of the black sheep of surgery. And my chairman's famous talk was that any surgeon who's doing more than 2 fusions a year for back pain is a bad guy. Is somebody playing around with my slides? Because I didn't do that. All right, let's see if we can catch up. But all that changed in 2000 because when the Charité wanted to start an FDA study, they were classified as a novel technology, as a class 3 device. There was no predicate that they could 510K to. And because of that, they had approved safety and efficacy. So the FDA required them to do a multi-center prospective randomized trial, and the same thing with ProDisc. So for the first time, within a couple of years, we were really forced into doing good science because we now had to identify a patient group with very clear inclusion-exclusion criteria. So these were patients from 18 to 60 with single-level disc disease who had to meet a minimum requirement for both VAS, ODI, and a bunch of other categories, but they were very carefully selected, externally randomized, not by us, not by the surgeons, but just by an external randomization algorithm, and then assigned a group. The patients were blinded before surgery, and then all the patients were followed the exact same way at multiple data points for 2 years, and ultimately for 5 years. So again, kind of with a gun to our head, we became scientists because we had to collect this prospective information on both the fusion patients and the fusion control patients, as well as the arthroplasty patients. So, remember the numbers I showed you about the paucity of data. Here you can see there was so much data generated by these FDA studies that, the science exploded, basically. There's a huge number of articles that are generated each year now on arthroplasty and the fusion control cohorts since year 2000. The seminal papers for the lumbar studies were Scott Blumenthal's paper in Spine in 2005 on the Charité study, and then the ProDisc study published also in Spine in 2007. So these were the 2 papers that published the data and outcomes that were presented to the FDA and the information the FDA based their commercial approval upon. Those cohorts were followed out for an additional 3 years, out to year 5. Rick Dyer published the Charité 5-year follow-up, and he found out there was no real difference in the ODI or VAS from years 2 to 5. So the significant improvement the patients showed in the first 2 years was maintained. Their range of motion was maintained. And the arthroplasty patients actually went to work and had less long-term disability. Rick Dellermatter and I published the 5-year ProDisc cohorts. Again, we followed those same patients in all the centers. We had 82% follow-up for 5 years, followed them out, and again, showed no significant interval change between years 2 and 5. One of the secrets is there was a Twolevel ProDisc study that started in January 2002, just about 3 months after we started the single-level study. And that took, same thing, patients 18 to 60 with 2-level disc disease, randomized them to a 2-level ProDisc or a 2-level 360. And that data was followed. The data was published in JBJS, and it was never commercially pursued. It was a strategic business decision by both Synthes and J&J not to pursue it, largely based on the reimbursement environment. But the data was published, the patients were followed, and as one of the last efforts of the ProDisc Publications Committee under J&J, Chris Radcliffe and a small publications group actually looked at and published the 5-year reoperation rates of the patients who had the 2-level disc replacement versus fusion. And there's a little more to tell about that story towards the end of the talk. But nothing went on actually between 2006 when ProDisc was approved until Activell was approved in 2015, except Charité was taken off the market in about 2011. So ProDisc had the lumbar market to itself for a few years, and then the Activell finished its study, got commercial approval, Rolando Garcia, and Jim Yu were part of the two co-designers for the ActiveL, and they published their 2-year outcomes data in Spine in 2015. And just last year, Jim Yu was the lead author on the 5-year publication. So just a couple of things to notice on the charts is you see both ODI and VAS show that same hockey stick that we're pretty familiar with in most arthroplasty studies, a big drop from pre-op. And, these patients were very disabled. They were very impaired with ODIs of 60. They only needed 40 to get into the study, but the average patient had a pre-op ODI of like 60. And a pre-op VAS for, remember, 6 to 9 months of failed conservative treatment of 8 out of 10. So these were hurting patients, chronic pain patients, really, and they dropped significantly and maintained that for 5 years. The other interesting thing about the ActiveL study, it was the first one that was commercially successful, that was a disc-to-disc study. So the controls here were not fusions, but they were ProDisc or Charité at surgeon's choice. So we really have a study here of 3 different arthroplasty constructs, with the ActiveL being the investigational one. So much data has been accumulated that it's even possible to select out 5-year outcome studies that meet pretty strict criteria and subject those to the more intensive analysis of a meta-analysis where you can use stronger statistical tools to evaluate. And this study, actually, Matt Dornett and I co-authored that with some really smart biostatisticians in Toronto. It starts out, as most do, with a literature search, and you get about 2,500 articles, and then start weeding out the ones that don't meet your criteria. So you're finally left with 4 studies that are 5-year prospective randomized, meet the appropriate criteria, patients are blinded, pre-op, etc. And those 4 studies are the Maverick 5-year study, Rick Dyer's 5-year Charité results, the ProDisc 5-year, and then a study that was a non-FDA study. It was even a non-US study. It was Scandinavian by Skold, and it used several different arthroplasty implants and several different fusion methods, but it was a multi-center, prospective, randomized, blinded study, so it met the criteria. So it allows us now to take all those patients as almost raw data and subject them to, again, more intensive statistical analysis. So now you ask the question, which group of patients, the fusion patients or the arthroplasty patients, were more likely to improve their ODI from baseline by more than 25 points? And you can see where the diamond is. It's over to the right side. So statistically significantly more patients in the arthroplasty group of all these pooled studies were more likely to achieve success than fusion. If you go to the second one, who's more likely to improve their VAS in their back pain, you can see it overwhelmingly, numerically is superior in the arthroplasty group. Because that little tail of the diamond sticks over the line, it's not statistically significant, but it is numerically significant. Third question to ask is, which group is more likely not to have secondary surgery? And statistically significantly, it was the arthroplasty patients. In fact, their risk ratio, you can see, is 0.5, which means it's only 50% more likely that they would require reoperation than the patients who are in the fusion cohorts at 5 years. And the last one is a question that the FDA is not that interested in, but we are. We're providers of care, and these patients are our customers. So this is patient satisfaction or willingness to have the surgery again. And again, statistically significantly, overwhelmingly in the TDR group rather than the patients with fusion. And again, this is international patients, multi-center prospective, different times, everything else, but homogeneous patient population. So that's why they're included in the meta-analysis. And with a small grant from J&J, we were actually able to reach out to about 65 of our TBI patients, and we got a 10-year data point because we were just kind of curious what happens between years 5 and 10, since 5 years was done as an FDA requirement, but 10 was not. And with those patients, we were able to find there was no significant worsening between years 5 and 10. in this small pilot group, and hopefully we'll be able to get more data. And I know that Esculap is committed to a 10-year follow-up point on the active L patients. So one of the big questions was, what about adjacent level degenerative change? That was really the holy grail of lumbar arthroplasty. Would patients develop less adjacent segment disease than fusion patients? So we were able to use the data from the ProDisc patients at 5 years. And what we asked the radiologist of medical metrics to do was to pull the pre-op films and the 5-year films on all the patients and score not the index level, but the adjacent level. So the radiologists didn't have a dog in the hunt. They didn't really care, whether a patient had a disc replacement or a fusion. All they were doing was assigning a score to the adjacent level preoperatively and postoperatively, and we asked them what % of patients were worse. So here's what they told us. About all the patients they looked at who had a fusion, 28.6% of the patients showed radiographic worsening at the next level. But of the patients who randomized to a disc replacement, only 9.2%. That's a 3-to-1 difference, and that is highly statistically significant. And again, this is an arm's length study done by the radiologist off digital measurements, not by the surgeons who might be, looking to cheat. So we went one layer deeper. We said to them, hey, listen, pull out the patients who had pristine adjacent segments. Pull out the patients who only had isolated single level disease whose adjacent level was perfect, and tell us what happened to those patients at 5 years. So they did. They found those patients, and the adjacent level worsened in about 24% of the patients above a fusion over 5 years, but in only 7% of the patients who randomly got a disc replacement. And that difference is really almost about 3.5 to 1, and that is even more highly statistically significant. So there clearly is a difference in the stresses that are put on the adjacent level above a fusion and a disc replacement that a radiologist can measure independently. We modernized that by looking at the degeneration of adjacent levels using the same scoring system with active L, but here we did it and introduced a variable of range of motion. So the question we asked was, in patients who post-op had less motion versus those who had better motion, degree by degree, what was the incidence of adjacent level degeneration, measured again by the radiologist at medical metrics off of digital films. And you can see that there is a linear inverse relationship. So if we did a poor job and the patient only had 0 or 1 degree of motion, about 11% of those patients showed adjacent segment change. But as we got down to more than 2 degrees, 3 degrees, 4 degrees, 5 degrees, we got to the point where if we gave 6, 7, or 8 degrees of motion, none of those patients showed adjacent segment worsening radiographically. So this is the first time that we're able to show that in the lumbar spine, that, again, there's obviously a benefit to motion as far as radiographically preserving the adjacent level. So the question came up in the year 2000 when we started these studies about anterior revision rates. There were a lot of naysayers who said you're going to have a lot of complications and these things are going to break and come out, and you're going to have to reoperate on these patients anteriorly, and you're going to kill a lot of patients. So what we did is look at our first 1,700 consecutive patients, starting with the first patient Scott did in the Sharpe study, pulling it through 2017. So we had follow-up on those patients. So of 1,707 consecutive patients over a 17-year time frame, there were 17 patients who needed anterior revision surgery, and they all did fine. They all survived. Fortunately, 2/3 of these patients are L5-S1, where it's safer to go back to rather than L4-5. 1% is 1% more than we'd like to see, but if you look at the spectrum of reoperation or secondary surgery in most spine surgery, this is a pretty small number, pretty low, and pretty reassuring to see that. As far as health economics goes, there have been a bunch of studies that show that segment by segment, disc replacement is cheaper than any fusion construct except for the patient's own structural iliac crest. And that's an operation I did as a resident and Dr. Lieberman did as a resident, but most younger guys have not done that because patients don't like giving up a chunk of the iliac crest. But anything you use that's commercially available is more money segment by segment. And there are health economic studies showing patients with disc replacement versus fusion get their function back faster, get back to work faster, have improved qualities, and lower adjacent level degen and adjacent level reoperation rates. So despite that, insurance penetration, meaning the percent of insurance-covered Americans, which is about 200 million, has remained really low for authorizing lumbar disc replacement. You can see from 2004 when the Charity was approved until about 2016, it was never more than about 20%. In 2016, after the Activell was approved, Esculap really worked hard to improve that and was helped with some class action lawsuits where patients got together and sued their insurance companies who changed their medical policies. So now the number is probably closer to about 75 and maybe even getting closer to 80% penetration. But the question is, with all this data, what would payers prefer that we offer patients who have failed conservative care? Long-term narcotics, which used to be the answer, was just send them to pain management. Well, that's not politically correct anymore. Dorsal column stimulators, and we've seen them at TBI, 35-year-old firefighters with single-level degenerative disc disease who come in with a stimulator that somebody thought was the appropriate treatment for them. Or super standardized multidisciplinary rehabilitative care. We get that thrown back to us by medical directors all the time, but who has a network for that? I mean, who has access to that? We don't. There is no standard criteria that you can send patients to that's the same all over the U.S. But the Scandinavians do. This is a study that was out of Finland that looked at total disc replacement versus multidisciplinary rehab with an 8-year follow-up of a randomized controlled multi-center trial. And their findings were statistically significant long-term results favoring disc replacement compared to rehab. So, that study's been done. I don't feel that we have to reinvent that wheel, but we still get pushback from a lot of insurance companies who think that structured rehab is a better option for patients in surgery. But, part of the issue is they keep moving the cheese. They keep moving the target as to what they want. So how do we fight back? Well, one is, working with the patients, and the companies, both Sentinel and Esculap, are really good about providing resources to the patients to help them fight back and use their rights for second opinions and appeals. We get our societies more involved. ISIS has been a really strong partner in establishing medical policy decisions and changes. NASA was a little slow to the table, but they're kind of catching on a little bit. And their policy statements from groups do carry a lot of weight with insurance companies. We continue to collect data. As I showed you, we're getting stronger and stronger as time goes on. And as surgeons, I think we have to continue to be responsible in offering treatment to the right patients. So where's lumbar disc replacement going? Well, I think first off, we're going to have some better tools in diagnosis. There are a lot of things at a research level, but there's a company that was just about starting a prospective study using MR spectroscopy, comparing outcomes in patients who had their discs appropriately matched to the abnormal one on spectroscopy versus discography. So that'll be a neat study and hopefully may give us a non-invasive diagnostic tool. New frontiers, I think there'll be new materials and designs. This is a viscoelastic implant that's available outside the U.S. There may be a role for biologic interventions. We keep talking about it. Unfortunately, it's still lots of years away. This is one of the pets of Rick Geyer, who always thinks that maybe there's a motion preservation bumper to use adjacent to these long level fusions that may cut down some of the failures that you see both proximally and distally to fusions. Here's a couple of ideas for some of the fellows who are listening. Nobody's really looked at that, but is there a construct that is better at L5-S1 as far as protecting the SI joint? It's an area that would be relatively straightforward to look at using computer designs or cadaver models. The other is level-specific implant designs. Is there a different design that might work better at L5-S1 than other levels? And again, nobody's really looked into that yet. And then we're just starting to look at arthroplasty in the super high demand patient, ultra high demand athletes and the military, where so far the current design seems to be doing okay, but maybe there's room for improvement to expand the indications into those patients. So here's the latest news is the SBLAP Publications Committee is currently working on a 7-year outcomes paper that should be submitted in Q3 or 4 of this year and hopefully published early 2021. And the hottest news is that Sentinel Spine just on Friday and announced today that they got FDA approval for the Twolevel Pro Disc, all based on the patient cohorts that we enrolled in 2004 and 2005. And finally, that data has matured enough that they got FDA approval for it. So things are moving forwards. This is just for interest. This was a patient I operated on at the end of the Twolevel study. So this was a guy who randomized. He was a 30-year-old engineer at the time. And he came back to see me in January because he had a cervical disc. And he had actually a cervical pro disc done. But I said to him, do you mind if I x-ray your lumbar spine? He said, sure. He said, but it doesn't give me any trouble. So here's a 16-year follow-up just from 2004 to 2020. And he's got really good motion at both levels. And he's got a little bit of an antiausterity at L3-4. But he's now, his mid-40s. He was a 30-year-old guy with 2 young boys. And he's a skier, snowboarder, Little League coach, the whole thing. And he's been doing that for the last 16 years. And clearly not beating up L3-4 as much as he would have if he had randomized to a Twolevel 360. So just it was kind of neat to see that. So again, let me sharing my passion with you that we've been good stewards, I think, of lumbar disc replacement. We've generated a lot of good scientific data. We've elevated the science from level 1B multi-center prospective trials to level 1A with meta-analyses of those trials. So we've done as good as we can do, and it's interesting that there are still people who think that it's not ready for prime time yet. So having said that, I've got a case, but I'm going to give it over to Alex Satin, one of our fellows, to show a case, and hopefully we'll get some discussion. And if there are people who still don't think this is the right thing to do, here's your forum. This is a good time to kick in and let's have some fun. So thanks for listening, and let me see if we can get Alex Satin's slides up. Alex, you there? I see you.
Yep, I'm here.
Great.
Good evening, everybody. My name is Alex Satin. I'm one of the TBI fellows, and I'll be presenting a interesting case from our practice. The patient is a 46-year-old male. His BMI is 25, which makes him a bit skinnier than most of our patients here in Texas. He has no significant past medical or surgical history, and he presented to our practice for a third opinion for the management of his chronic low back and left lower extremity pain. The prior 2 surgeons both recommended fusion, albeit by different techniques for his symptoms. He's a former Marine and previously had an active lifestyle, playing with his children, doing yoga and mountain biking. You can see that he was pretty significantly disabled due to his symptoms. And his symptoms had started around 10 years prior to his presentation, but were significantly worsening over the last 4 years. And he had extensive non-operative care and was not getting any lasting relief. On exam, he did have some subtle weakness in his left foot and altered sensation in L5 pattern, and he was pretty significantly limited in regards to motion due to this pain. Here are his x-rays. He had no coronal abnormality and reasonably well-maintained lumbar lordosis. He did have some transitional anatomy with a rudimentary S1, S2 disc space, and you can clearly see that there are pars defects at L5 with a corresponding grade 1 to 2 spondylolisthesis. And then there's also some decreased disc height at L4-5. MRI at L4-5 demonstrates decreased disc height and signal with desiccation. The facet joints at this level are relatively normal, and there's no central canal stenosis. At L5-S1, you can once again see the pars defects and the associated listhesis. There are modic end plate changes and no central stenosis here either, and he's got left greater than right lateral recess and foraminal stenosis. Given the patient's symptoms, imaging, and failure of conservative care, the decision was made to proceed with surgery. Due to the instability at L5S1, we agreed with the outside surgeons that fusion was appropriate at this level. We chose ALIF with posterior instrumentation, allowing for a radical discectomy, a large surface area for fusion and reduction of spondylolisthesis, as well as increased cranial caudal dimensions of the foramen. However, due to his lack of instability, we felt that, and preserved facet joints at L4-5, we recommended a disc replacement at this level to address his degenerative disc disease. And he did have a preoperative DEXA scan that was normal. So here are his post-op day 1 standing films, which are part of our routine. He underwent a successful hybrid reconstruction. We utilized a 6-degree active L implant at L4-5 and a 12-degree 15-millimeter height interbody at L5S1. And he was discharged home without issue on post-op day 1. We saw him in the office for 6-week post-operative follow-up. He had near complete resolution of his back and leg pain, slowly getting back to his activities. And you can see at the flexion extension films that he does have good motion at the disc replacement.
Hey, Dr. Beccaro, what operation does he get at Rothman, do you think? One?
Well, no. Rothman doesn't do total disc replacements. And I'll tell you the reason why we don't do it. Our access surgeons aren't the best. So I think you need to have a slick access surgeon. And ours are good, safe access surgeons, but they're just not, they don't expose the disc space well. I end up doing most of the exposure and I can get myself in trouble. So this patient is going to get an anterior posterior fusion. It's not going to get a disc arthroplasty. Cervical arthroplasty we do all the time. Lumbar arthroplasty. And another hang up at the Rothman Institute is the need for revision besides going laterally, the need to potentially go anteriorly, and the fact that you can get into problems with catastrophic bleeding has always been something that has bothered Rothman Institute physicians. So those are the two hang-ups that we have, basically.
But Alex, Jack showed you some very, very wonderful data, and you can't dispute the data. And for a 30-some-year-old guy, would you rather have a 2-level fusion and come back in 10, 15 years and reconstruct with 3-4, or do something like this? And maybe you should try to get a better access surgeon. Maybe you should have someone get the experience and be trained. It is, once they learn the technique, we do it not with our eyes closed, but our access surgeons are really, really good. And I'm not suggesting you do something that's unsafe, but maybe you should think about getting someone who's well trained in doing access, because it is really a simple operation. These patients go home in less than 24 hours.
It's interesting. I'll tell you, I haven't thought about it much recently because I don't do it. But when I began thinking about it and I began seeing the follow-up and I began seeing, all I do is, as a surgeon, I focus on the complications because I figure out the surgery in my mind. I figure out how to make the steps more efficient and safer. And then I say, how am I going to get myself out of trouble? If I could design an arthroplasty device, which people have attempted, to be placed posteriorly from a posterior approach, protecting the anterior scarring, the potential, I would do it in a second. I would do any motion-sparing device that can be placed posteriorly. The problem is it doesn't exist. The problem is you cause instability. It'll have to be like an anterior posterior motion-sparing device. That, if we can get there, may be the future. Because remember, a revision procedure anteriorly can be a very bad day for the best of surgeons. And that's the only thing I worry about. Jack has great hands. You have great hands. You've got great access. So, it's something I'm thinking about. First of all, the most convincing lecturer in the world is Jack Zigler. I feel good. I stopped drinking my wine when I heard him give a speech because I had this sort of warmth feeling because he communicates effectively and I believe him. But for general adoption, only for the revision procedure is something that bothers me.
But Alex,
Rick, let me just cut in. We've got 2 questions from the audience that we'd like to address. And Jack, possibly you can expand on this, an idea that, or an issue that Alex brought up. the difference in access between an ALIF and a disc replacement for one. So I don't think everyone really appreciates that. And then the one question was, why did you include L4-5 in the patient case that you presented? Did you do discography at 4-5 pre-op? All the symptoms could have been from L5-S1.
Izzy, I can answer the second question.
Yeah, let me address the first one, and then either Alex or Rick can talk about the second one. But you're right that the access for an ALIF doesn't have to be as broad and direct as it does for a disc replacement. For disc replacement, you got to be straight on, and you have to be able to see all the way to the right and all the way to the left, which is not an issue, but it's all the way to the right, especially at 4-5 or 3-4. So you have to have the good access surgeon, whereas you can do an ALIF off to the side, you can do an OLIF, you can put in a T-lift cage from the front if you get stuck with bad access. So, and as Alex alluded to, an access surgeon is key. I mean, he's the most important part of the team. And, you know, we tell our fellows once they show it to you, there's no excuse for not doing a good job. It's just carpentry. You just have to just be meticulous, but the access is absolutely necessary. Rick or Alex, you want to talk about L4-5?
I'll answer the question because it was my patient. So this guy was, in great shape. He was normally very active, except for the spondy. And the question was, why did you include L4-5 when the problem was probably coming from L5-S1? Well, we had that discussion, and the patient was such that he said, Doc, you know, I've had this chronic back pain, and if you just fix 5-1, what if I have problems at 4-5? Can we fix that? I said, yes, we can go back and fix it later. He said, well, why can't you do them both at the same time? I said, that's an option as well. So the one option would have been just to fix L5-S1 with the right-sided approach, and then come back later if he had a problem with the 4-5. So we discussed the pros and cons. I did not do discography. The remainder of his spine looked perfectly normal. He was a straight shooter, not taking any heavy-duty medication other than anti-inflammatories. He and I made the decision to go ahead and include the L4-5 because, as you well know, if you do a fusion adjacent to an already degenerative disc disease or degenerative disc, it eventually is going to give you problems. And we have clear data, long-term data now.
Izzy, I think there's another question about lordosis. Do you want to read that one?
Sure, I've got it. I've got it right here. And this, I guess, is directed to the study authors, particularly you, Jack. Have you ever explored the differences in lordosis at the index level between fusion and TDR as it relates to ODI and VAS? Is the reason they feel good potentially auto-regulating their ideal PILL mismatch and lower lumbar lordosis?
That hasn't been looked at, and probably the data's there. So, you know, if somebody wanted to do the research on it, you probably could look at those differences. But I think you're exactly right, theoretically, and that's what Carey Mone always said. He said the spine will find its own centers of balance and rotation with an artificial disc. And if you guess right and dial in the right amount of lordosis in a fusion, we know that patients will have a better longer-term outcome than if you guess wrong and fuse him in kyphosis and really screw up his measurements. But you make that decision at the time of surgery, whereas with an artificial disc, the patient can make that decision, or his body mechanics will make that decision for you. And we do think that's one of the reasons why the Holy Grail came true, that there is less adjacent segment degeneration radiographically, and there's less adjacent segment disease. There's a lower reoperation rate in patients who randomly got an arthroplasty versus a fusion. I think it's a very good question, and there's more research that can be done looking at the exact angles, which hasn't been done yet.
Hey, Jack, Bay has a question for you, and it's, go ahead, Bay, you ask your question.
I can actually ask it, Jack. I want to get your opinion. Alex talks about doing a revision anterior, but for a well-placed artificial disc, if the patient continues to have pain and there's no catastrophic failure in the artificial disc, do you feel comfortable with just doing a posterior fusion only or do you feel like you have to go back and take the disc out?
Yeah, we look for any reason not to go back anteriorly, for the reason that Alex said, because it's potentially life or limb threatening. So we'll do it if, God forbid, there's an infection or displacement with vascular injury. So if our hands are forced, we'll do it. But otherwise, if it's just for continued pain, we'll do a posterior fusion. The problem is you don't get a home run. You don't hit a home run with those patients. You make them a little bit better, but nobody's really happy when that happens. But we certainly don't go back anteriorly unless we have to.
Do you feel that the reason you don't hit a home run is because you may not understand the disease, or do you think it's because you haven't been able to do an anterior revision on the patient? Meaning that hey, the patient has back pain, we're not sure of the source, and that's why you're not hitting a home run, or is it because I failed to do a good anterior construct, and due to that fact, I'm not getting pure fixation, and therefore the patient's still having pain?
Yeah, maybe both of the above, and even the third one is that it's a patient factor, because we all know, you can do a perfect operation on some people, you're not going to get them better. Scott Blumenthal, you want to add anything to that?
I don't think he has audio, but Jack,
Jens, maybe he does.
Scott? Maybe not. Rick, what were you going to say?
Yeah.
All right. Jens has a question for you, Jack.
Sure.
Hey, so this is, first of all, your group, and you deserve such credit for having really worked with a procedure that was almost gone and really scientifically kept it alive and brought it to the forefront. And so that's kudos to you and your group's excellence and dedication to really being precise in reporting and surgery and selection. Now, here's my question. So in the beginning, this procedure was intricately involved in discography. And sorry, Rick, Guy, I'm not going to let you off easily here. How do you really know that a disc is painful? Again, discography, I don't want to get into that whole morass now. But again, everybody has some form of disc degeneration. Do you use modic changes? Do you have to have a certain Furman grade of degeneration to qualify as painful, or is it after a presumption? So any thoughts on how do you select in your mind that this is a painful disc that can benefit from a full replacement is indeed in front of you? Thank you.
And someone also asked if SPECT CT can be used to identify the painful disc. So address the same thing in that question, please.
Well, Jens, you raised a great question. In the beginning, we published a lot on discography, and we thought it was the end-all and be-all. And I think that as time has gone on, we're becoming more and more selective in understanding the true discogenic pain patient, the good patient that is a great candidate. So first, it's the history of discogenic pain. And secondly, it's a plain radiographs. You get your MRI scan. Modic changes are not necessarily associated with pain. So we had discography for a while, and we only will check an abnormal disc. And we only do it in those cases that are questionable. If they have a single abnormal disc and they have a classic history, they've gone through all the, hoops and, everything conservatively, then if they sound reasonable, we'll proceed. We may do facet injections. And then if there's any question, the discography. But Jack alluded to a new study from Nociomed, and actually Macronet has discussed this a lot, but they don't have a good randomized study that we're going to be studying, is on MR spectroscopy, in which they actually can measure the phospholipases and the other chemicals within the disc, a correlation between the degenerative disc. Now, another thing that's come about is the MR is the bone spec. We don't have enough experience with that, but it would be an interesting study to compare the three modalities, the SPEC MR, the bone scan spectroscopy, or SPEC bone scan, and discography, to see if we can hone it down. So I don't think any of them are perfect.
Yeah, we're hoping that we'll have a non-invasive test if the MR spectroscopy works out, because it turns out the biochemical markers are different in a painful disc and a non-painful disc.
Can you hear me?
By looking at explants from scoliosis releases in non-painful anterior discs, the chemistry is different than it is in patients who have low back pain from disc disease. And Matt Gornett did a study just at his center where he correlated it with discography. So as Rick said, if we can do a multi-center prospective study and show that it will predictively show us the disc that's causing pain, and the patients who have that disc operated on do better than the people who had a different disc operated on based on clinical intuition, then that may prove the point that we have a non-invasive test for pain, which would help a lot in this business. Hey, can we move on, have our next fellow present a case, just to get some more involvement? Alex, who's up next, you know?
John.
John, where are you?
I can get the slide to advance here. Not giving me the tools to advance the presentation.
There you go, John. It's moving.
Okay. So I'm John Burleson. I'm another one of the spine fellows at TBI. I'm going to do a case that's a little bit different. We do a lot of arthroplasty at TBI, but it's definitely not all we do. This is a case here from our level 1 trauma center, Physical Spine Trauma Center in North Texas. So we're doing a decent amount of stuff there. Let me get to the slide that I want here. Let me see it. Okay. So 64-year-old guy came in. He's a little bit of a bigger guy, actually has an interesting history, was being seen previously by our ironically on-call spine surgeon for some neck issues. But this time he came in before his next scheduled appointment because he fell asleep at the wheel driving his big rig. Reportedly left the ground, almost flipped this semi over. Obviously got him to the hospital, checked him out, looked at everything, and then the only real issue that he had was his injury I'm going to show you. Had a 2-level burst fracture. He previously had a burst fracture in his thoracic spine that was fixed posteriorly. When we see him this time, he's got issues in bilateral lower extremities. As you can see there, his strength exam is decreased. He's got pain. And on, let me get that slide. There we go. There's a couple sagittal images of a CT scan. You can see that L2 and L3 both affected there. And then I'll show you some MRI pictures. These MRIs and CT also looked at by the radiologist, and there was concern for some blood in the thecal sac on this imaging as well. And then obviously the neuro changes, 2-level burst fracture. So we discussed this all with the patient and made the decision to take him to the operating room that night to stabilize his injury here. I'll go over some more imaging in a moment, but so the not as interesting part about this case is the normal stuff with the burst fracture. So we did a standard midline incision, made the normal approach down to the lumbar spine. We saw what you would expect at L2 and L3, even posteriorly, that the tissues were disrupted, as you can see on the MRI scan. And we fixed it as seen here. We use the arrow navigation. So we're pretty happy with where our screws are placed. The reason why I'm presenting this as an interesting case is this is about 1 in the morning now, and my attending and I were having a discussion that I think he knew how it was going to end when we started it. But he asked, based on these images with this laminar fracture, if I wanted to do a decompression. At 1 in the morning, I just trying to talk him out of it because I think there's no reason to. It's fine. We stabilized and he's having the pain because of the burst fracture. And he kind of explained that, well, the risk with blood in the thecal sac and with this laminar fracture is that he could have some entrapped nerve roots, could have damaged the dura. We don't know. We should explore this. So we did, and ended up making the right decision. So I apologize. We didn't retain the digital camera that Jack Zigler had 15 years before somehow. So we have really bad pictures of the microscope spectrum, which is what you're looking at here. But what this is this is some 6.0 Gore-Tex sutures tagging the edge of the dura. What we initially saw when we first started doing our laminectomy at the 2 affected levels was immediately nerve roots or rootlets trapped in the lamina. They clearly split apart, come back together, and trapped on the neuro elements. The dura was actually folded kind of behind these nerve roots. So when we opened up the lamina, we're just staring at spaghetti and had some real concern for not being able to repair the dura at all. But upon further inspection, going laterally on both sides, we're able to see the dura underneath these nerve rootlets, pulled it up, tagged it, and you can see it there. Here's a better picture here after we've kind of tagged. This is a 2-level laminectomy. So this is L2 and L3 that we've been able to kind of put all the neural elements back in. Nothing seemed to be completely severed, just, excuse me, some areas that were a little less happy from being pinched, but most of it seemed intact. And then we were able to kind of close up the dura there. You can see the bunch of knobs. That's the fellow section, and the rest of it is where Dr. Eric sewed it up. So to have that closed, we put, I think we put DuraGen and DuraSeal on top of it, but we did 2 Valsalvas and had no leak. And we're able to close it up. Weren't quite sure at the time how well he would do with his neuro exam, but in the hospital he ended up doing great, and he's up to 6 months out now. No wound issues, no hardware issues. He's able to walk independently, uses some support or assistive devices occasionally, but his pain is decreased, and overall very happy with the outcome here. So I thought, at least as a fellow, definitely a unique case I hadn't seen before, and reminded me that even if it's the middle of the night, I need to go through the steps for totally planning out the surgery, even in a trauma situation, make sure I don't miss something. Because if it was just me and I hadn't had this case, I wouldn't have done a laminectomy, and I would have done this guy a disservice. So.
Hey, Alex, would you have done anything differently? Would you have opened up?
No, I like the way it was done. I agree.
No, I'm saying, what would have convinced you not to do a laminectomy? Do you open up all laminar fractures?
No. I would open up a laminar fracture. If there was an obvious neurologic deficit that couldn't be explained, I would do that. If not, I would not have touched it.
Wait, but he had a burst fracture. That's not enough to explain his neurologic deficit?
That could be. So, I mean, you look at the original articles, if there's a laminar fracture and a burst fracture in the setting of a neurologic deficit, there's a chance that there may be a laminar fracture. If the neurologic deficit cannot be explained precisely, I would go posteriorly. But remember, you get yourself in a ball of trouble opening up a laminar fracture if there's no obvious CSF leakage. So you have to be very careful. In a situation like that where I think there may be disruption posteriorly, I may go anteriorly, and then I may percutaneously place screws and ignore it unless I think there's an obvious benefit I can afford. Have you gone posteriorly sometimes in some of these burst injuries and see the dura shredded like you saw here? It's a potential problem.
I know. So, John, having been there, did you see the actual nerve roots trapped in the defect or not?
Yeah, so that was that was probably the part that was the most shocking to me. Was, we left a little soft tissue on the lamina because we were just instrumenting the spine, and then as I start getting towards the laminar fracture itself, we slowed down, and it was just like this, oh man, moment when you see literally a nerve root pinched in the lamina. And then as we moved caudal, I should point out, we only went caudal because we did the laminectomy and we're kind of following the dural tear down and realized it's going under L3. Only at that point did I realize there's a laminar split on L3, not easily visualized on the CT scan, but the same thing, a different nerve rootlet trapped in there. So you could clearly see this piece. And like I said, it made sense to do it, but like Dr. Vaccaro mentioned, when we first looked at it, I really thought we're just going to be gluing this and praying for something and have a bigger problem. So, at least digging around the side and spending some time to try and find the dura. In this case, we were fortunate that it appeared to just be a pretty clean vertical split of the dura we were able to repair. But.
Great.
One of the most sobering cases I remember as a young attending was just about to take my cob and strip off the paraspinal muscles when I realized that there were roots superficial to the lamina, that they had exploded out through the burst dura and through the ligamentum flavum. So if I didn't see that, I would have taken a cob and I could have done a lot more neurologic damage. So that made me be very respectful of operating on patients with these lesions.
Well, it's reminded me that when I did this originally, that, if I was doing a revision case, we would be very gentle going down to that level. And that needs to be the approach that I have anytime there's a laminar fracture, something that's not normal anatomy. I just need to very gently dissect everything and make sure that, I'm taking care to do that and not just blaze through it because it's a trauma case. So certainly was a game changer case for me.
Yeah, it's a good case to see. All right, you want to go, who's up next? Alex, Abi?
Yeah, can you see me?
Yep.
Yeah, I can see you.
All right, guys. My name is Abhiram Gandhi. I'm one of the other fellows here at TBI. I'd like to present another case from the trauma center. This is the case of a 44-year-old female. She had a prior surgery in Oklahoma, L5S1 fusion, and presented with an 8-year history of radiculopathy and neurogenic claudication. She also had a previous, in the interval since she saw us, she had a spinal cord stimulator implanted for this worsening progressive pain. Obviously, it didn't work. She's had an extensive conservative sort of workup and management with little relief. Notably, she's significantly morbidly obese with a BMI of 46.5. Going to her preoperative images, this is a previous construct. One of the screws is broken, but it's that level is solidly fused. However, there's an adjacent segment disease with a grade 2 spondy at L4-5 with a flat back, the lordosis being approximately 35 degrees on this series of films here. Moving on to her CAT scan, this is just confirming once again, she does have a solid fusion at the L5S1 level with signs of stenosis at the adjacent level. Not sure if these videos will play. Okay. Well, this is just, I wanted to include this series of videos just to confirm the previous findings with the spinal stenosis, adjacent segment disease at the previous level, and no signs of pseudoarthrosis at 5-1. So our plan going into this, you could skin this in multiple ways. You could do a posterior only fusion, you could do anterior and then posterior, or you could go lateral. And that's what we did. L4-5X lift with a laminectomy posteriorly to decompress that level with screws. Well, open screws, but yeah. And this is her final construct. A couple of things that I took away from this case was we had trouble with preserving the anterior longitudinal ligament. So that and when we wanted to prep the disc space for the X lift, so we ended up compromising that, and that just led to global instability with that segment. And we do quite a bit of X lifts at MCP, the trauma center, but this is one of the first times where we had that occur in the surgery, and I didn't see appreciate that kind of instability before, and it's just one of the things to keep in mind when doing these laterals. And we ended up using a tabbed implant to secure that level provisionally, and then also had to do a reduction maneuver posteriorly after flipping her over and putting in the posterior pedicle screws. This is not the implant that we use, but it's an example of an invasive system. We only used one screw in the L4 body. So, the take-home points for me is whenever you appreciate, collapsed disc space preoperatively, make sure that you have these tabbed implants available and ready to deploy if needed, because it becomes quite unstable in this situation. And it's also important to perform a reduction maneuver because you want to get the lordosis back as much as possible, especially in this case when she has the hypolordosis on the preoperative imaging. So those were the take-home points in this case.
Thanks, Abhi. Can we go to some of the questions from the floor? Izzy, you want to go back to those?
Sure. There were a couple questions. One in particular regarding the dural repair case. Was that Gore-Tex used? It looked like an extensive reconstruction. John, you presented that one? Was there that was Gore-Tex, I presume?
Yeah, it was all Gore-Tex. It was we kind of changed course halfway through. There was a little ways when we were doing interrupted, and then there was a little bit of it that we kind of did a running one. I think it ended up being 5 or 6 of the 6.0 Gore-Tex. It just, the properties of Vortex just make it, for those of you that haven't used it, it's just so much easier to handle than the equivalent strength Proline. It doesn't have any memory. It's a lot easier to tie the knots. And so for me, as a real amateur, I certainly appreciated that. But that's what we had there. That's what we used. We did some running, did some interrupted.
Good. Another question that had come up, Dr. Zigler mentioned something about biomechanical differences between TDR and lumbar fusion, which was based upon clinical observation, or was this based on clinical observation? And have you studied this at the TBI Gate Lab? Maybe Rick, you can take those.
Izzy, we're actually looking at the Gate Lab right now at our disc replacements and diffusions, but we don't have any data to report on yet. It's been debated with the very high sacral slope that in general we don't use disc replacement just because of shear forces, but we don't have the biomechanical data to back it up. And of course, you have the different slopes that will make it much more difficult biomechanically for the artificial disc, such as a very, very high sacral slope. So it's something we need to look at, but we have.
All right. And Jack, maybe you want to expand on that same comment about the sacral slope pelvic parameters, how they play into the decision to perform either an ADR or an A-lift.
Yeah, ignorance is bliss sometimes, Izzy. Since we started doing these before we started measuring all the angles, what we kind of found is that it's the access that limits your choice. So if you cannot see your sight line all the way to the back of the disc space, and you can measure that out or draw the lines on pre-op films. So if patients have a very high sacral slope or sometimes an L6S1, where the anterior disc space is going to be out of your direct visualization range during surgery, we talk those patients out of an ADR because we can do an A-lift without seeing all the way in the back with the help of fluoroscopy and being a little judicious with curetting, but you cannot do a posterior release unless you can see the posterior annulus and do a release under direct vision. So we screened those patients out, and it was really because we were afraid that the access would be inappropriate. There are patients who are close, and I just make sure that on those patients that I do an eyeball conversation with them. We consent every one of our lumbar ADR patients for a fusion, and that's routine. But for the patient where I really have some concerns about whether we'll get the appropriate visualization, I make sure that I have that conversation with them eye to eye so that they understand if we cannot get the visualization. Now, most of the time in the OR with them relaxed and with a little bit of a lumbar bump or breaking the table, we usually can get a better exposure of the back of the disc space than we thought. But every once in a while you cannot, and that's where we make sure the patients agree that if they wake up with a fusion, it's because that was the best thing for them. But we sort of blundered into that without measuring the angle, so I can't really tell you that there's an absolute angle that is a contraindication, because really the access and visualization of the disc space would preclude your being there for a disc replacement.
Good. And one other question here for you, Jack. You mentioned in the talk that the changes in adjacent level deterioration at 5 years were something like 28% for the TDR versus 9% for the fusion. The question is, are we just kicking the can down the road? Do you have any idea what the 10-year results are? And are the two curves staying parallel in the next 5 years, or are they coming together in the next 5 years?
Great question. And, data is going to answer that for us. So, in fact, I was just on the phone today with some of the people from Medical Metrics about doing the exact same measurements now on the 7-year active L patients who have come in and their data is already digitalized, and then do the same thing again in 3 years when we have 10-year data. So we'll be able to linearly follow patients through their different time points. But I think we all thought that within 2 to 5 years we were not going to see such a big difference. because clinically, we would tell most patients it'll take 10 or 15 years before you'll get adjacent level breakdown with a fusion. And it's not an absolute number, but that's sort of the range we would tell people. So none of us really thought we'd see much of a difference at 5 years when we did that study. And we were just shocked to see the significance of the difference between the two radiographically when you use an objective scoring method. So it was an eye-opener for us, and it'll be interesting to see if it's a linear progression over time. But time will tell. But we're on the way. We're working the data.
Awesome. Do we have time for more questions?
Well, it is 5 afterwards, but so we can either do a little more questions or do one more case. Domingo, do you have a short case or a long case?
Mine's fairly short. I can run through it real quick.
Domingo's, and then we'll wrap it up so that people can get on with their lives.
Okay, so I'll run through this case real quick. My name is Domingo Molina. I'm one of the other TBI fellows. So this is a cervical myelopathy following a C6-7 disc replacement. It's a 36-year-old, previous car accident in 2002, had severe whiplash, did relatively well with the non-operative treatment, and started complaining of right arm pain. Underwent a C6-7 arthroplasty in 2017 for cervical stenosis. Patient postoperatively noted that he had complaints of left arm paresthesias, mainly down the 4th to 5th digits. Physical exam included a positive Hoffman to the left upper extremity, hyperreflexic lower extremities, as well as upper extremities. Did have some decreased muscle strength, 4 out of 5 left tricep, and did have positive limit and Sperlings bilaterally, and did notice some fasciculations in the hands as well during strength testing. These are the pre-op images from 2017 before his disc arthroplasty. As you can see, large disc herniations, posterior osteophytes at C6-7. The foramina look relatively okay. Most of the pathology is centrally located, causing some central stenosis there. Underwent a disc arthroplasty with MOVC. These are the post-op images in 2017. Critiquing these, you can see that the disc is a little bit posteriorly placed on the lower end plate, perhaps maybe even a little bit on the upper implant as well. These again were taken in 2019. Patient underwent a CT scan again, demonstrating posteriorly displaced cervical disc arthroplasty, causing some central stenosis. So our plan, of course, the imaging demonstrated the disc was posteriorly displaced into the canal, causing some cervical myelopathy. We recommended a C6-7 implant removal, partial corpectomies, and conversion to a fusion. So this is a patient postoperatively, approximately 2 weeks out here, and these radiographs. Patient stated that his symptoms were improving, regained full muscle strength in bilateral upper extremities, still had some hyperreflexia in the lower extremities. Gait symptoms had improved as well. As you can see here, we didn't have to take as much bone as we thought. I believe this was a size 11 peak cage that we used, and everything went well postoperatively there. It's the last, it's the last slide there for that one.
All right, Domingo, thank you. Let's wrap it up. I think this was a good first time off, and hopefully everybody got something out of it, and it was worth giving up an hour of our evening and afternoon. So please join us next week. Next week, Dr. Chapman's got the floor, and Jens is going to talk about cervical laminoplasties. Linda put up the slide or Alexis put up the slide that shows how you can get your CME credits for this. And, we'll welcome comments, if there's stuff we can do to make it better, if this format could be buffed up a little bit, just let us know. But I just want to thank everybody for presenting. Thank the TBI Fellows and the Seattle Science Foundation again, as well as Dr. Chapman, who's probably 2-3 whiskeys ahead of us. So thank you. Thanks for doing a great job, everybody. And everyone stay safe.
2 hours behind us and 2 whiskeys ahead of us.
Yeah, that's right. Stay safe. We'll see you Friday morning for Journal Club if you can make it, but otherwise next Tuesday night for Dr. Chapman. All right. Good night, everybody. And thank you.
Good night, everybody. Good job.
Yeah.